Hi, everybody. Welcome to the MGFA What's New in Research webinar series. I'm Jenna Mbalo. I wanted to welcome you all here for today's talk on Take On Your Tomorrow with gMG. We've got a great presentation ahead of us. We'd like to go over a couple of housekeeping items. If you have questions, please put them in the Q&A box located at the bottom of the Zoom chat bar, and we'll get back to them during our Q&A segment. Today's presentation is recorded and will be available online after the presentation. I'd like to give thanks to our sponsors for the research series: Alexion, argenx, Janssen, UCB, Horizon, and Cabaletta Bio. And now I'd like to hand it over to our team that's going to be presenting, Dr. Andrew Gordon and the team at Alexion. Welcome.
Hi, I'm Dr. Andrew Gordon. Am I going to be starting oh, here we go.
You got it.
Well, thank you so much for joining us today. Really appreciate your time, and there'll be a chance to ask questions in the chat. And so thanks for joining us. So what we're going to be talking about is myasthenia gravis, right? And specifically what's new and how Ultomiris, a new treatment, may be an option. This is a sponsored program. I'm compensated for the time. And reminder, during this presentation, please do not take photos or videos of the presentation. It will be available online afterward if you want to review any of the slides, as was stated earlier. And please silence the cell phones, although I think everybody's on mute. And remember, this is intended to be educational for everybody, patients and their caregivers, but it does not replace your own doctor's assessment. And there's no way that specific medical advice can be given just based on slides and so on. So you really have to individualize your care with your own doctor. And I think I'm going to hand it over to Cynthia for a moment.
Great. Thanks, Dr. Gordon. And I'll just do a quick little overview on what we're going to learn about today. So I'm going to give a quick overview of Alexion's mission and really a little bit about our inspiration. And then Dr. Gordon's going to really dig into more of the detail on what the causes are of gMG, how gMG affects daily life, and then, as he already described, a new gMG treatment option. So for just a quick overview for folks that I may not have met, my name is Cynthia Cassandro, and I'm the Executive Director of Alexion's Global Patient Advocacy Team. And I'd really like to thank Jenna and the entire team at MGFA for the opportunity to be with all of you today, and really thank each of you for spending your afternoon with us. And before Dr. Gordon moves into this presentation, I'm just going to take a quick minute to share a little bit about Alexion's corporate mission and some of our key milestones as an organization. In summary, really, Alexion's source of inspiration is you. You are what ignites Alexion's passion and our mission to help those affected by gMG and other rare diseases. And through this really important focus on the patient and listening and truly partnering with the community, I want to highlight a few of our key milestones. So Alexion has a long history in rare disease. In fact, this year we are celebrating 30 years of leadership in the rare disease community. And this leadership, and through this leadership, we've achieved some pretty incredible milestones that we're really proud of. One of them is the Prix-Galen Award, and of which we've received 4. And folks might not be familiar with what the Prix-Galen Award is, and this is considered the pharmaceuticals industry equivalent of the Nobel Prize, and it's the highest accolade for pharmaceutical research and development. We also have 5 unique therapies or treatments, FDA-approved treatments across 7 different types of rare diseases. We serve patients in 50 countries throughout the world, and this is really important for us to be able to spend this time with you as we talk about new treatments for gMG. So with that background, we're going to get back to the purpose of our time today. I'd like to thank you, Dr. Gordon, our speaker, and I'm going to move and advance the slide and turn it back over to you.
Great, thank you, Cynthia. Okay, so what causes myasthenia gravis in the first place? What are we really dealing with? When you have myasthenia gravis, it's important to to have this discussion with your physician too. It helps outline what are the treatment options. It's when we focus first on what the cause of the problem is in the first place. In MG, there's a problem with disruption of the nerve signal to the muscle, right? There's antibodies blocking the nerve signal, and these antibodies target the muscle membrane. And so if the nerve signal is not getting to your muscles, then clinically there's going to be weakness. And MG is an autoimmune disease. It's a rare autoimmune disease. In neurology, there are other autoimmune diseases, MS, et cetera. This is the most common autoimmune disorder of the neuromuscular junction, though. So while rare, it's not ultra rare. Doctors who specialize in MG have dozens and dozens. I've 75 or 80 of these patients. So there's a lot for a rare disease. It's somewhat common. And when we say autoimmune, right, we mean that our own body is making antibodies that mistakenly attacks some part of our body. In this case, again, the muscle membrane interfering with the nerve signal. And in the United States, while a rare disease, about 71,000 adults do have generalized myasthenia gravis. In younger women, there's a peak incidence with many of our younger women in the 20s and 30s having myasthenia gravis. And then there's another epidemiologic peak in middle-aged to older men, interestingly. So there can be young men and older women, but our two peak incident groups are the younger women and older men. And really key point is that we've had treatments for a long time in myasthenia gravis, but many patients still have lots of symptoms, residual symptoms, despite best treatments and best practices. And when we think about our symptoms, right, they can be described in various ways. The antibody status, are you antibody positive, antibody negative, what type of antibody? And also, is it ocular or generalized? And the majority of patients with myasthenia gravis will have generalized symptoms, but often the condition starts with ocular, and it may, in some cases, stay as only ocular. And when we say ocular, right, we're talking about double vision, droopy eyes. When we talk about generalized, we're talking about symptoms of trouble swallowing, trouble speaking, perhaps shortness of breath, facial weakness, trouble smiling, raising the arms and legs, or getting up and down stairs. So do you know your antibody status? This is important. Many of our treatments work specifically based on whether a patient has acetylcholine receptor antibodies. So it's important to know your status. And as we mentioned, acetylcholine receptor antibodies, it's important to recognize that the vast majority of myasthenia gravis patients have these antibodies. This is the most common scenario. About 85% of myasthenia gravis patients do have acetylcholine receptor antibodies. And again, an antibody is naturally produced in the immune system. We all make antibodies all the time, right? And in autoimmune disorder, antibodies are misdirected in a sense and really targeting some part of the body. That's rheumatoid arthritis, other things too. And here in myasthenia gravis, there are a few other antibodies too, but they make up a very small percentage of cases, right? MuSK, LRP4. Again, the vast majority of patients are acetylcholine receptor antibody positive. And the way you make this determination is with a blood test. So looking a little deeper, delving a little further and peeling the onion back, right? To understand myasthenia gravis, let's look at the normal state first. In people without myasthenia gravis, the nerve terminal releases acetylcholine. And in the normal state, this acetylcholine then binds receptors on the muscle membrane, activating an action potential and in practice then activating the muscle for movement. This is the normal situation. Complement plays a role in disrupting communication between nerves and muscles in people who are acetylcholine receptor antibody positive. And this is because the antibodies activate complement, which we're going to talk a little bit more about. But what is complement? Well, complement is, as it's named, a set of proteins, about 40 or so proteins that serve the role of complementing other parts of the immune system. And that's why these proteins are called complement. The complement helps your immune system fight off other threats, such as bacterial infections. And in acetylcholine receptor antibody positive patients, complement is actually activated by the presence of these antibodies. So acetylcholine receptor antibodies activate complement, and complement then builds up on the muscle membrane, contributing significantly to weakness. How does complement disrupt and cause problems? How does it disrupt communication between nerves and muscles? Well, when patients have acetylcholine receptor antibodies, the complement system is activated, and complement then binds and deposits on the muscle membrane, leading to loss of receptors, actually. So receptors are lost, receptors become malfunctional. And as you can see here in the visual, this damaged muscle tissue shown on the right, you lose these folds. So there's a lot of surface area in the healthy state where lots of receptors covering the membrane of the muscle are available there, ready for binding with acetylcholine in the healthy state. But in the damaged muscle state of myasthenia gravis, complement deposits have built up, interfering with the ability of a nerve signal to bind a receptor, because literally there are less receptors. You lose the receptors in the presence of complement deposition. And that's shown here. Complement attacks the muscle, depositing itself there and destroying receptors, damaged muscle tissue. So in that case, when the nerve signal releases acetylcholine, there's usually no receptor there to bind it. And that's why with the complement activation, there is such significant weakness. The message can't be delivered from the nerve terminal to the muscle membrane. Complement activation, as I've been describing, right, it damages the muscles, and this leads to a variety of challenges in people who are antibody positive. Like what? Well, double vision, droopy eyes, right? Trouble speaking, chewing, holding the head and neck up. I've seen that many times. Many MG patients have trouble holding the head up, difficulty swallowing, and difficulty with choking on food, even aspiration, where the food goes down the wrong way, trouble with breathing, and of course, limb weakness of the arms and legs. And these will be fatigable symptoms typically. And let's think about your life or the life of someone that you know who has this condition, right? When we say the fatigable symptoms, often symptoms are mild or minimal when sitting in a sedentary state, but more active and more prominent when the patient is doing things or when the patient is exerting themselves, right? So maybe double vision and droopy eyes will come on towards the end of the day, or with reading or driving. Speech may become a problem when delivering a speech or having long conversations with people or talking to people at work, colleagues. But speech may be okay for yes and no in simple sentences, right? So these are fatigable symptoms. Chewing and swallowing problems. Maybe it's okay for soft food, but harder for the patient to chew and swallow food that requires more exertion, right? Solid foods. Trouble breathing. I have had many patients with shortness of breath, but primarily if they have to walk across a large parking lot or a big store, a Walmart, a big box retailer, these things can be really disabling, right? And debilitating if you're not able to even go to the store and stand in line for a while and walk across all the aisles. Patients will have trouble completing just daily activities. It may be tiring just to brush your teeth, comb your hair. So again, maybe in the static or sedentary state, the symptoms may be okay, but if the patient has to exert themselves, these symptoms as listed often will come on. And that significantly affects quality of life. So, it's important to recognize the symptoms. Every symptom is important. If you're experiencing symptoms that are mild, moderate, or severe, quality of life can be significantly impacted. A lot of MG clinical research is done in patients who have mild and moderate symptoms. So it's recognized that mild and moderate symptoms can be very disruptive. One way we evaluate and make sure that we're picking up on all symptoms, severe and moderate and mild, is use an instrument or tool called the MG-ADL. And so let's talk a little bit about that. It's important to know your score. This is how we determine if a patient is controlled, not controlled, need more treatment, doing okay. We use the MG-ADL score. So if you've been diagnosed with generalized myasthenia gravis, the MG-ADL is a very simple way for you and for your doctor to understand how much the MG is affecting your life. Tips for taking the MG-ADL: fill out the MG-ADL every 3 months, or whenever you're not, when you think you're having a bad day, fill it out. There's no right or wrong answers. It's just an instrument, a tool that we use to gauge how you're doing. A caregiver or friend can help you with the answers. Sometimes they notice things you may not. We see that a lot. Remember to write down any changes that you have, write down any changes you have made to accommodate your symptoms. I think this is really important. So, you know, we mentioned that many patients may have fatigue with brushing their teeth. Well, if you're switched to an electric toothbrush, great, that may be good for your teeth. But if you're doing so because you don't have the strength to brush your teeth with your own hands, you know, that's a sign. That's a bad sign that we want to make sure we're addressing. Same with making accommodations in the diet or being less active, as I was mentioning earlier. I have patients that, you know, maybe they don't go to the store anymore. They don't make plans with friends or are not working full time because of the symptoms that, because of their MG symptoms. It's important to make note of that because our goal is to restore function and for everybody to have as best a quality of life that they can. And I just want to say time, you know, it's important to think about the past month or so. The MG-ADL is not how do you feel right now, but also how have you been doing over a longer period, about a month, and think of how you were doing at your worst. So here's the MG-ADL. There's 8 different domains, right? So all the things that we've been talking about, you know, the ocular symptoms like double vision and droopy eyes shown at the bottom. And of course, talking, chewing, swallowing, breathing, use of the arms for basic function like brushing hair and combing, brushing hair and brushing your teeth and getting up from a chair. And with each of these domains, you know, you'd get a 0 point for feeling normal. 0 is good. 1 would be the symptoms are mild or, you know, intermittent. 2 would be moderate or more like a daily. And 3 would be severe, meaning, you know, in a lot of these domains, constant. So that's how we rate it. So a 1 or 2 point change can be pretty significant, right? The maximum score with 8 domains up to 3 on each would be 24. You know, so 0 would be perfect, 24 would be really, really bad. So once you know your score, what would you do next? Make your MG-ADL part of your routine. Talk to your doctor. You know, if you're noticing an increase in your MG-ADL, let your doctor know. And it's really important, you know, to think about what would a 1 point, 2 point, 3 point change mean? This is not like cholesterol or blood pressure or something where a couple points doesn't really mean that much. 2 or 3 points could be the difference between having a feeding tube and having normal swallowing, right? Or having a lot of shortness of breath, maybe even needing a ventilator and having normal breathing. That's just a 3 point difference. So a couple points, 3 points, you know, is a significant difference. Okay, so we've talked about how even with, you know, standard treatments, many patients have a lot of residual symptoms. We've talked about how we evaluate patients. Now we're going to shift gears a bit and talk about a new treatment option that can help reduce the impact of generalized myasthenia gravis and improve scores on the MG-ADL. So Ultomiris is the first and only approved long-acting complement inhibitor for patients who are acetylcholine receptor antibody positive. That's how it's indicated. Similar to Soliris, we'll talk a little bit more about that. And there's important safety information to be aware of. I mentioned similar to Soliris, if you're familiar with that. So Ultomiris is longer acting, but as a complement inhibitor like Soliris, these medicines both block complement. That's how they work. We talked about already how complement is important. Blocking it interferes with the loss of receptors, which is a good thing. We don't want to lose those receptors. But when we block complement, we also have less immunity against certain infections, particularly meningococcal infections. And Neisseria meningitidis is a bacteria that can cause meningitis. So everybody who gets treated with Ultomiris should receive meningococcal vaccinations, and it should start the vaccination series 2 weeks before the first dose of Ultomiris. If you're already on Soliris and switching, you don't have to start over again. The point though is if you're naive to complement inhibition, you need to be vaccinated. And it's possible in some cases, if urgent treatment is needed, the risks and benefits are weighed, and the benefit of starting as soon as possible with Ultomiris might outweigh the risk of meningococcal infection, and in which case your doctor may opt to give you antibiotic prophylaxis while awaiting the effects of the vaccinations. Yeah, and so we give boosters for these meningococcal vaccinations. You know, we'll get into this a little bit more, but and your doctor will know about this, but like a lot of vaccines, they don't last forever, so we give a booster. Meningococcal vaccinations do not eliminate the risk. It's important to know that, but they significantly lower the risk of getting ill with one of these infections. And patients should be watched for, fever, signs of meningitis, fever, chills with a severe headache. Rash is actually a common scenario with meningococcal meningitis or altered mental status. Okay, so we've talked about Ultomiris as a treatment that targets a specific part of complement. I think that's important, specific parts. So actually, this is a very targeted therapy. It binds one complement protein, C5. It does not interfere with the entire complement system. What we call the proximal part, or the majority of the complement system, is actually not affected by this therapy. Ultomiris binds C5, complement protein C5, with very high affinity. And that's important because it's C5 activation that leads to these deposits on the muscle membrane that I mentioned earlier. So by blocking C5, we don't get this buildup of complement deposition on the muscle membrane. So the CHAMPION MG clinical trial was the pivotal trial for Ultomiris that wanted approval in treatment of generalized myasthenia gravis for patients who are acetylcholine receptor antibody positive. And in this trial, the impact of Ultomiris was measured by using the MG-ADL in the treatment group, but also in the placebo group. And the quantitative myasthenia gravis scale, or QMG, was also used. So the MG-ADL, as we talked about, is just self-reported, right? It's patient reported. The QMG is physician administered. So it's a little more rigorous, right? Because it's physician administered with some equipment. It has to be used as well. So in the CHAMPION trial, about half the patients were randomized to Ultomiris, the other half were randomized to placebo. This was a blinded trial. That means all the people evaluating the patients, did not know whether the patient was on treatment or placebo. The study went on for 26 weeks, and then in an open label extension trial, the placebo patients were crossed over to Ultomiris and followed out for up to 4 years. So we have a long duration of data. Researchers in the clinical trial used the same MG-ADL assessment you saw earlier, right? So that's shown right here. So yeah, it's a standard tool used in most clinical trials for myasthenia gravis. It was used here. And when the trial began, I think this is really important to hone in on. Sometimes we think of patients who, will only enroll in a trial if they're super severe or once they've failed everything. But in this trial, actually 90% of the participants were MGFA class 2 or 3. MGFA class 2 means really mild symptoms, not ocular, but mild generalized symptoms. And class 3 would be moderate. So, the vast majority of these patients in the clinical trial were mild or moderate. They had to have at least an MG-ADL of 6 to be enrolled. And they were not required to be on prednisone, but 70% were on some steroid. So 30% maybe had been on it, but went off it, or just were not on any type of steroid at all. So it's not a requirement in this trial and then in practice for patients to, fail high dose prednisone first or something like that. And same with immunosuppressive therapies that are non-steroidal. So we're talking about azathioprine or mycophenolic acid, Celseft. 68% of participants were on at least one of those. But again, not all. So it wasn't the case that you had to do those things first. So as we go through this and look at some of the patient profiles, it's important to consider, ask yourself, are you like the people that were enrolled in this trial? 10% were severe, but actually 90% were mild or moderate. Have you been on prednisone? Many of these patients were, but some of them were not. How many other therapies have you tried? There was no requirement to try other therapies first, but certainly the majority of patients in the trial had been on other things. What is your MG-ADL score? And are you content? Are you looking for symptomatic improvement, or are you functioning fully, at your normal healthy state? If everything is perfect and you're at total perfect health with no MG symptoms, that's great. But if you do have residual symptoms despite prior therapies, this may be an option. In the clinical trial, there was significant improvement in the MG-ADL score in patients treated with Ultomiris. So Ultomiris showed a greater than 2 times improvement compared to placebo. So as shown here, the Ultomiris patients had an average of 3.1 points of improvement versus 1.4 points for placebo. In all clinical trials, we'll always see a little bit of improvement with placebo, the so-called placebo effect. And so when we look at a therapeutic medication like this, you want to see that the medicine is better than placebo. And, and that's what we saw here. And on the QMG, same kind of thing, even more than, significantly more than double the improvement in the Ultomiris group versus placebo, 2.8 points of improvement on average on the QMG versus 0.8 for the QMG. And, just a reminder with safety, Ultomiris is only available through a program called REMS, the Risk Evaluation and Mitigation Strategy program, basically, which just means that the doctor is informed and signs on to monitoring for meningitis, aware of the safety issue, that everyone will get vaccinated. And patients are given a safety card, which just sort of outlines what we talked about a bit earlier. What would it look like if you had meningitis? What are the signs and symptoms? I haven't had a problem with meningitis in any of my patients treated with this, but it's really important to always have it in mind and be on alert and be on the lookout, because that is the one significant safety issue here. More patients on Ultomiris improved their QMG by 5 or more points than placebo. So I said, there was roughly 3 points of improvement on average, but a lot of patients had much more improvement than 3 points. Some had, many had more than 5 points of improvement, which is, pretty significant on the QMG. 30% of patients who experience Ultomiris experience a clinically meaningful response versus 11% on placebo. 30% had a more than 5-point improvement, 57% had a more than 3 points of improvement. So, the majority of patients had significant improvement when they were treated with Ultomiris versus 34% of the placebo patients. So again, whether it's 2 points or 3 points or more than 5 points of improvement, what would that mean for you, right? 5, 6, 7+ points on the MG-ADL would be huge. Even as we talked about earlier, 2 or 3 points could be really significant. The difference between a feeding tube and swallowing normal is only 3 points. And okay, so we've established that Ultomiris leads to significant improvement in the majority of patients. What about safety? So serious side effects were reported in some patients. 20 people with MG receiving Ultomiris versus 14 of the placebo patients. There was some diarrhea, some abdominal pain, some upper respiratory tract infections, back pain, dizziness. As you see, looking at Ultomiris versus placebo, some of these are similar in the two groups, but there was a little more, there was more abdominal pain in Ultomiris. Don't know why that is. We don't have a good answer. I haven't seen that in my patients. And dizziness, 9% versus 3%, also a potentially significant difference. And diarrhea was the number one thing, but I actually haven't seen that in my patients so much. One thing about diarrhea is, of course, Mestinon also causes that, and most of these patients are going to be on Mestinon. So it's important to watch and monitor for side effects in these patients and in anybody on any therapy. In the open label extension study, we gathered more data up to 4 years. And in the open label extension study, all of the patients who enrolled received Ultomiris, right? So what we're talking about is patients who had placebo now crossed over in an open label extension study. It's no longer blinded. When you start treatment, of course, it's very important to first receive the meningococcal vaccinations. So they're given in a series, and the first vaccine in the series should be started at least 2 weeks before starting Ultomiris, and then the remainder of the vaccination series can be completed while on therapy. Again, vaccination does not eliminate the risk of meningococcal infections, but it certainly lowers the risk. So that's why it's now critical to get vaccinated. And meningococcal meningitis, I should tell you too, this is not something that's out in the community all the time everywhere. It comes in little outbreaks, typically amongst close quarters, like maybe the military. It's happened at college dormitories. This is the type of meningitis that we're talking about. And it would look like, as we talked about, confusion, fever, rash, severe headache, stiff neck, sensitivity to light, fever and muscle aches. Those are the things to watch for. And the safety card I mentioned is shown here. It just kind of lays that all out. So patients and families are aware of what, what is this, what are we watching for? What is the safety issue? Okay, so what is Ultomiris from a practical standpoint? What we're talking about is an infusion therapy. This is given every 8 weeks. So that is a difference compared to, some other therapies, Solaris, for example. And we talked about side effects to watch for, maybe diarrhea, maybe abdominal pain, and any infusion related reactions are always important to watch for with any IV therapy. This is an IV therapy. So, rash or allergic reaction, these are all things that it's important to watch for. The infusion can be given in an office setting, at home, or at the hospital. The recommended dosing regimen starts with an initial dose, and then 2 weeks later, you are given maintenance dosing. And the maintenance dosing is every 8 weeks. So again, there's an initial therapy or loading dose, if you will, and 2 weeks later, a maintenance dose, which is calculated based on weight. And then, so it's a little different based on each individual. And then the maintenance is every 8 weeks. So that's a significant difference compared to some of our other therapies, obviously, given every 8 weeks, a little longer period of time. The infusion lasts about 1 hour, a little less than 1 hour, and then patients are monitored for an hour afterward, just to make sure there's no infusion-related reactions. So yeah, Ultomiris is already, it's approved for MG, of course, as we've been discussing, but it has several other indications. It's been studied in multiple clinical trials, more than 10 now, and it's been in the marketplace for more than 3 years. So it's not brand new to medicine. It's new for MG, but has been around a little while and pretty well studied with an established profile. Ultomiris may help people like you manage your symptoms. That's what we're getting at. We don't want people to live with residual symptoms that interfere with quality of life, interfere with work or social engagements. We want people to be as normal as possible. And Ultomiris has been shown to reduce the MG-ADL, reduce symptoms and lead to improvement on the MG-ADL, which, as we've talked about, that probably means something for most patients, right? A couple points, 3 points, 5 points would be a big deal for most people to have a drop like that on the MG-ADL. It has been shown to help improve functions such as walking, talking, swallowing, right, breathing. And it has been shown to deliver improvement in muscle strength. And again, this is all by blocking complement. It's a very targeted therapy. It doesn't, suppress the whole immune system. And in patients treated, again, we want to be just watching for, diarrhea and upper respiratory tract infections and any potential side effects like we've been talking about. Okay, so OneSource is a benefit, a program that Alexion provides to help people navigate the landscape, finding an infusion center, navigating the insurance issues. And it's been wonderful. I've had patients, get a lot of help from OneSource. And I think I'm going to pass it to Cynthia to give a little bit more information about OneSource.
Hi there. Actually, my name's Kathy Logan.
Kathy, I'm sorry.
You're
already
good.
Had a chance
You're
to speak. It's Kathy's turn. My bad. Go ahead.
Absolutely fine. Again, thank you so much for that information, Dr. Gordon. I'm going to talk a little bit about OneSource. My name's Kathy Logan. I'm actually a patient education manager at Alexion. And so for those of you who aren't familiar with OneSource, just as Dr. Gordon just stated, it is the complimentary patient support program offered by Alexion, really here to help so that you're not alone in your treatment journey, a multitude of resources, and someone's going to be there with you throughout every step of your journey. So within OneSource, we have different team members who you may be in contact with as you kind of navigate your treatment from the beginning all the way through continuation. So patient navigators really are going to be involved with you from your initial contact. They're going to help give you that initial information about Ultomiris, but also help understand some of the different resources you have. Patient liaisons are another is another group of individuals who really might have that information for you as you continue on your treatment. And then we have our patient education managers, such as myself, who will really take part as you continue your treatment and really help connect you with the community, and can provide you further treatment education, but really information on local events in your community. So with OneSource, we really focus on 4 pillars that you really see here on the screen. OneSource can offer you educational materials and really useful information regarding your gMG, whether it's brochures, information on Ultomiris, the treatment process. And then we can also provide information, understanding your insurance plan as it relates to Ultomiris and coverage options, as well as our team is really involved in helping provide information really to those of you who might have some gaps in coverage, let's say, or out-of-pocket costs, and provide you with some external funding resources as well. We can also provide you information on community activities happening in your area locally, whether they're in person. We also can connect you with webinar information, events happening, and really connecting with others in the community who may have similar gMG symptoms, or really might, if you want to connect with somebody who's also on treatment, to speak with them. So ongoing support is really the overarching pillar that really is going to provide that support for you from the beginning of your treatment all the way throughout your treatment journey, just to really help ensure that there's no interruption in your treatment. So really, I hope today, kind of what I want to say in summary is, I hope that everybody after today's talk really feels empowered to talk to your doctor about your treatment options and really whether Ultomiris might be an option for you. You know, and I say this because if your life is really truly affected by your gMG symptoms at all, I hope everybody feels okay to talk to your doctor and just ask the questions. So I'm going to thank everybody for coming today. There's some other information links that you'll see on the screen. At this point, I'm going to turn it back over to Jenna, and where we can start some Q&A.
Hi there, thanks so much. So we definitely have some questions that have come in. The first one is, if neck weakness is common and I can state from experience that it is frightening, why is it not on any of the assessment instruments, particularly the daily living assessment, which is used in drug trials?
That's a great question. So neck weakness, you know, head drop, if you will, is sometimes caused by other things. So it's not just MG, but if it's related to MG, it can be really limiting. It's not on the MG-ADL. It's just one of those things that when the MG-ADL was made, it wasn't included. I don't know why, but what I can tell you is it probably correlates with some of these other things, like people who have a head drop often will have other things that do show up on the MG-ADL. And it's also important to remember the MG-ADL is just an instrument. So nothing replaces a good history physical exam. So, you know, as someone who sees a lot of MG, right, you know, I'll do the MG-ADL, but I'm still going to spend time talking to my patient and digging a little deeper. And a head drop shouldn't get past, you know, someone who shouldn't get past a doc who sees a lot of MG. So it should be factored in. And again, I think often people with a head drop will have other things that do show up on the MG-ADL, but even if they don't, it's a problem in its own right that needs to be treated. So we don't just treat the MG-ADL, you know, we treat the patient.
Thank you. This next one is, what is the current availability of Ultomiris in the US? My neurologist reported not being able to get it.
Oh, it's available, you know, a couple weeks, at least a month or so, a little more than a month, I think now.
And what is the recommended method of changing from Soliris to Ultomiris?
Okay, so if you're doing well on Soliris, first of all, it's important to know you don't have to change, but it will maybe be more convenient. And so if you make the switch, the way you would do that is literally when it's time for Soliris, you would do Ultomiris in the loading dose, and then 2 weeks later, you would receive the maintenance dose, which is every 8 weeks. So it's a very logical, clean switch. When you're ready for Soliris, you simply are given Ultomiris in the initial dose.
Thank you. And so this kind of relates with that. How is Ultomiris dosed as compared to Soliris?
They work very similarly. There's a couple differences. Ultomiris is longer acting, and the way that it's longer, it's just specifically engineered in a way to be recirculated into the bloodstream, and actually uses a mechanism through FcRn so that it gets recirculated back into the bloodstream and it lasts longer. It was engineered to do that. I think probably, some of the feedback on Soliris was obviously that every 2 weeks was tough for some people. So that is the main difference. I think it's important to understand it binds very quickly with C5 Ultomiris. So it's not the case that it's like extended release. Because you may have to, if you have experience with certain medications that are extended release, they may have a slow onset of action. That's not the case here. This does bind C5 very quickly, and Ultomiris showed benefit within a week or two, just like the trend was showing benefit very early on, which is what was which is what's established with Soliris. So they're actually very similar. You can think of it as lasting longer. A dose of Soliris might be given in some patients in the hospital because it's only good for 2 weeks, and a hospital patient isn't expected to be in the hospital for 8 weeks. So there's maybe a few differences where Soliris could be preferred, but basically from a convenience standpoint, this is going to be easier. It lasts 8 weeks.
Thank you. How does the mechanism of action of Ultomiris compare to that of Vyvgart? Which mechanism of action would you prefer?
Oh, it's not so much a matter of preference, and they've never been studied or compared head to head. So, we can't say that one is better or one is worse or anything like that. But from a just descriptive standpoint, the way Vyvgart works is it binds FcRn actually and outcompetes IgG antibodies, so that IgG antibodies are then destroyed or brought into what's called the lysosome of the cell so that they get destroyed, and the acetylcholine receptor antibody level drops. Other IgG antibody levels drop too. So Vyvgart is effective, but its safety issue would be that you're going to have dropping antibody levels. In the case of complement inhibition, the mechanism is not so much with the antibody, but with the complement, right? So we're talking about binding complement to preventing complement deposition, but no specific effect on acetylcholine receptor antibodies or Ultomiris. And so here, as we've talked about, the safety issue is not a drop in antibodies, but specifically a meningococcal meningitis issue or concern, because it's complement that's involved in providing some immunity against meningococcal infections. So I hope that helps. It's a good time, maybe a paradigm shift where we have lots of new and robust therapies available that all could be used earlier on, and as opposed to waiting to fail every older therapy that maybe suppresses the whole immune system. We now have lots of robust therapies that may be available earlier on. And whether it's Vyvgart or Ultomiris or Soliris, that's up to your own, that's going to depend on individual treatment considerations, individual patient considerations that you would address with your doctor.
Great. Is the delivery of the medication, i.e. infusion versus oral tablet, the primary difference between Ultomiris and the drug in the ALXN 2050 drug trial?
Can you repeat that question?
Is the delivery of medication, i.e. infusion versus oral tablet, primary difference between Ultomiris and the drug in the ALXN 2050 drug trial?
Yeah, I'm not sure which one the ALXN 2050 drug trial is, but just to give you a little background, right? I mean, there's oral, there's some of these medicines being studied sub-Q, some are being studied IV. There's a whole range of things, and there's different mechanisms. We just talked about FcRn, there's different mechanisms. There's also different points in the complement system one could target, but I'm not sure which one ALXN 2050 is. And unless something's been published, I wouldn't want to about it. I wouldn't want to comment on it unless there's something specific about it. If you have more information about it, I could probably give you a little more of a response. I just don't remember which one 2050 is.
Okay, that's all we have on there right now. Okay, let's do this one. Somebody already asked, we answered about Ultomiris compared to Vyvgart, but how do you decide which one to use? My doctor mentioned both are potentially relevant for my affected family member.
Mm-hmm. Yeah, there's a lot of ways to look at it. Both are, have a lot of data to suggest efficacy, right? Perhaps if you've just been vaccinated, that would be something to consider as a concern with Vyvgart. Right? If you've just been vaccinated and you require urgent therapy, I mean, we know that IgG levels will drop when you give someone Vyvgart, right? So you would want to wait a little bit of time if someone just received a vaccination, for example, before. You wouldn't want to concomitantly be vaccinating and giving Vyvgart at the same time. So that would be one consideration. If maybe with Vyvgart too, there's special concern for urinary tract infections if that's been an issue. But it works really well too, right? And then if we look at Ultomiris, I mean, if anyone's had meningitis, maybe had problems with Neisseria meningitis infections in the past, or maybe couldn't complete the vaccination series, for some reason, or isn't able to get vaccinated, or has side effects and can't complete the vaccination series, then maybe Ultomiris wouldn't be a good option for that patient, right? So you kind of have to weigh the pros and cons, and both are going to be effective for the majority of patients. And as we talked about earlier, in contrast, it's really maybe the biggest difference is lumping these medicines together and comparing them to something like prednisone, where we have a lot of safety issues that really are not rare, but are part and parcel to being treated with prednisone, long-term weight gain, hypertension, diabetes. So there's some special considerations, Vyvgart, Ultomiris, others, but even after those considerations, these generally have fewer side effects than something, like prednisone or azathioprine. Does that help? I'd probably direct you back to your doctor too, to address specific differences for you based on your profile and what other medications you're taking and what your infection history is and your ability to take vaccinations or what recent vaccinations you may have already had. Those are the kind of things that weigh into it.
Thank you. It's really helpful. Well, I think that's all the questions we have today.
Okay.
So wanted to, 1 minute, I think we got another one. We have one more. Are any of the newer therapies appropriate for use in I think it's IRP4, gMG?
LRP4. No, none of these have been approved for LRP4, unfortunately. I'll just lay out one other difference, obviously, is the dosing regimen. That's a key difference between Vyvgart and Ultomiris, right? So Ultomiris is every 8 weeks. Vyvgart is going to be variable from patient to patient. Some patients might go longer, many might not make it as long as every 8 weeks. So it's just going to depend. So I think that's an important difference too. Vyvgart was studied with a variable or kind of flexible dosing regimen, and Ultomiris is every 8 weeks. So 8 weeks is a long time, that's pretty good, right? Vyvgart, the patient may go that long, they may not.
Great. Well, thank you so much, Dr. Gordon. Thank you to Cynthia and Kathy and the team at Alexion. Thank you everybody for joining us today. This concludes today's webinar, and we hope that you can join us for the next one. Take care.
Thank you, everybody.